इसमें उठा दो, डाल सकते हैं।
बस Good afternoon, Subhanu.
Good afternoon.
How are you, ma'am?
I'm fine. How
I'm okay.
where are you here or our thing in
in
Clatterbridge?
in Clatterbridge only, ma'am.
Okay.
We'll be starting soon.
Sure.
So shall we start?
Yeah, sure.
Yes. Welcome to Mahamana case discussion series and happy Teachers Day to all. So today we have the privilege of hosting Dr. Abhishek Mahajan. He is a professor, Department of Radiology, Clatterbridge Cancer Center, NHS Foundation Trust. So he will be delivering a talk on imaging and its implications on the treatment in laryngeal cancer. Welcome, sir.
Thank you. Can you allow me to share my screen, please?
Yes, sir. I will
Sure.
just- You can share your screen, sir.
It still
Are you
says
able to?
no, you cannot start screen share
One.
while the other participants sharing.
Yes, 1 second. Let me just. Can you please try now?
Mm, Sure. Okay. Mhm.
Yes, we can see your screen.
Sure. Thank you. Thank you, and thanks to Aseem and Sabani ma'am, for giving me this opportunity to speak on this topic. In the next 20 to 30 minutes, I'll just pass through the anatomy and various critical structures which uh, imaging explores the extent and the spread, which has implication while planning the management of these laryngeal and hypopharyngeal cancers. So imaging definitely isn't complementary to the clinical examination as well as the endoscopic biopsy, which routinely is being done in patients with laryngeal and hypopharyngeal cancers. But subtle abnormalities and spread into some spaces and fat planes is not seen on endoscopic examination. And there comes the role of imaging. It becomes a choice whether you want to pick up a CT or an MRI. But given the advantages of rapid acquisition, CECT definitely scores over MRI. An MRI can be kept as a problem-solving tool when you are facing motion artifacts, when you're facing difficulty in assessing the cartilage involvement or paraglottic space involvement. So cross-sectional imaging is really important because it not only tells you the spread across the paraglottic space involvement of the cartilage, but also helps into assessment of the nodal disease and also distant metastasis. Given that the hypopharyngeal malignancies are quite aggressive, they have large nodal burden and can be advanced. In such cases, PET-CT or NCCT thorax can be added onto the staging workup of these patients to rule out any pulmonary metastasis or bony metastasis. So, what are the key spaces we will see in the anatomy, which is important and seen only on imaging? Starting from how do we divide the larynx? So the larynx is divided into three parts with three critical structures. The three critical structures here are the false vocal cords and the laryngeal ventricle, followed by the true vocal cords. Now, anything above the laryngeal ventricle is the supraglottis. Between the true glottis, that is the true vocal cords, is the structure which is the glottis, and anything below the true cords is the subglottis. The diseases of the supraglottis tend to come with a lot of spread across the spaces, extending up to the preepiglottic space. The glottic diseases tend to have a lesser degree of nodal metastasis or incidence of nodal metastasis as compared to the supraglottis, and subglottic extension can happen due to transglottic spread as well. Now, starting from the anatomy, the first structure to identify is the inverted U-shaped structure, which is ossified, that is the hyoid bone. So the moment you see hyoid bone, you will see the area epiglottic folds and the piriform sinuses. So the median glossoepiglottic fold and the area epiglottic fold would form the area, which is the piriform sinus. The hyoid and the thyroid cartilage have a thyrohyoid membrane and a small structure which is seen very well on sagittal reconstructions, that is the hyoepiglottic ligament. The space between the two forms is the preepiglottic space. The preepiglottic space continues along the fixed edge of the epiglottis and goes down into the paraglottic space. So there's communication between preepiglottic space and the paraepiglottic space. At the level of the thyroid cartilage, when you see a gray fat containing structure, and you start to see the arytenoids just at the tip of the arytenoids, that is the area of the false vocal cords. The false vocal cords would continue for a while, and you'll see that the cricoarytenoid joint has just started to appear, but this is still appearing gray. That is still the area of the false vocal cords. The moment you see the cricoarytenoid joint proper and a hyperdense structure which is slightly of the fat of the muscle intensity, that is the vocalis muscle. The vocalis muscle denotes that you've reached the glottis, and the insertion of the vocalis happens at the anterior commissure. So when the anterior commissure hosts the insertion, there is deficiency of the perichondrium in this region, and it is the attachment of the Broyles ligament at this space. Why it is important is that the disease of the anterior commissure have the high propensity of thyroid cartilage invasion because of this deficient perichondrium in this area. So the cricoarytenoid space is also very important structure. If the disease is reaching in the cricoarytenoid space, the patient might be having a dysfunctional larynx, which will be a contraindication to function preserving treatment options. As you go further down, you start seeing the appearance of the cricoid, and that is the area which is the subglottis. Now, how to identify if you just want to identify based on the lumen, the false focal cord would have a triangular lumen. It appears like a triangle. At the level of the cricoarytenoid, when you see the glottis, it will have an oval lumen, and the subglottis will have a round lumen. So from triangular lumen to oval lumen to subglottis, which is a round lumen. I did mention about the preepiglottic space, and this space is best seen on the sagittal reformats. So why this space is important? Because involvement of this preepiglottic space can guard prognosis if patient is treated with chemoradiotherapy. So the structures over here are the hyoid bone, the thyroid cartilage. This is the thyrohyoid membrane anteriorly, and this is the hyoepiglottic ligament. Now, the space between the thyrohyoid membrane and the hyoepiglottic ligament is a fat-containing space, that is the preepiglottic space. It's difficult to assess preepiglottic space through contiguous axial sections, and I suggest and recommend that sagittal reformat should be checked for excluding preepiglottic space involvement. Now, this is a busy slide, but if you look at the staging framework over here, most of the spaces cannot be seen clinically. Most of the extensions cannot be seen clinically, especially the cartilage involvement, pre and paraglottic space involvement, or post-cricoid extension. This is the need that we need to assess these on imaging, and that serves as the purpose whether we can give organ preservation treatment option to patient, or is it the surgical option which is the best suited for the patient. The primary goal here is disease control, and the secondary goal is the larynx preservation. So now I'll show some cases with disease spread patterns, and then we'll see what are the treatment implication of these spread patterns. So the first case over here is a supraglottic laryngeal cancer. I've shown over axial, coronal, sagittal images, and you can see that there is a proliferative mass which is involving the right vallecula. It's going into the suprahyoid and infrahyoid epiglottis over here. So the supra and the infrahyoid epiglottis both are involved. And then there is median glossoepiglottic fold involvement as well. So you can see the median glossoepiglottic fold is also involved. So this is a supraglottic malignancy involving the epiglottis. And there is an uninvolved epiglottis over here. So this is the normal appearance of the epiglottis. There is involvement of the pre-epiglottic space as well. And this is the disease spread pattern over here in the diagrammatic representation. Can you see my arrow? Pointer options. Okay, now.
Yes, sir. It's
Yeah. So pre-epiglottic space involvement is very well highlighted over here, and this is the invasion of the pre-epiglottic fat pad, which we've seen over here by the disease. The next case is a case of the supraglottic disease again, but only restricted to the false cords. And you can see that the disease over here is involving the paraglottic fat pad and the space reaching up to the cartilage, but no cartilage involvement. You can see very well over here on the coronal reformats that the disease is only restricted to the false cords. At the level of the true cords, the normal signal intensity pattern is maintained. There is no altered lumen or any bulge. And this is a disease not involving the glottis. Followed by a true glottic disease, and represented over here by circumferential involvement of the laryngeal lumen with focal cortical erosion on the right side and significant luminal narrowing, which led to need for tracheostomy. So this patient has a few findings which are very significant and suggest that this patient is not a candidate for CTRT. That means the cartilage is involved, the cricoretinoid space is involved, there is sclerosis of the arytenoid. At the same time, the paraglottic space is also involved. So this is an advanced disease with dysfunctional larynx, and the patient is a candidate for surgery. Another example of disease spread with through and through cartilage destruction and exolaryngeal spread through the thyroid membrane and through the cricoretinoid space as well. So this is widening of the cricoretinoid space, which again suggests that the larynx is dysfunctional and patient is a candidate for surgical option. The next is an example of a transglottic malignancy, and you can see the spread pattern over here, how the disease has gone from the glottis to the supraglottis. It's difficult to ascertain the epicenter of the disease at this point. There is significant destruction of the cartilage, the greater cornu of the thyroid cartilage, exolaryngeal spread, pre-epiglottic space involvement, paraglottic space involvement, nodal metastatic disease over here, and significant encasement of the CC. So this is an advanced cancer again, reaching up to the post-cricoid region as well, which is a surgical candidate. A subglottic extension can also again be challenging, and this is a glottic malignancy which has reached up to the subglottis, is actually breaching the anterior cortex and involving the anterior visceral space. There is a further down extension, and this also guards the type of surgery the patient would require. This is an example of an hypopharyngeal malignancy. You can see the disease epicentered at the piriform sinus. It is extending caudally, involving the false cords as well. And the disease spread pattern is along the paraglottic space fat pad. So the disease can extend along the paraglottic space fat pad, reaching up to the true cords. There is bilateral metastatic nodal disease, which is large volume, as normally seen with advanced hypopharyngeal malignancies. This is a disease restricted to the postcricoid region, and the axial sections, you can see that there is a focal thickening of circumferential thickening of the postcricoid region, and these to distinct whether the prevertebral fascia is involved or not. It's important that if there's a large volume disease, a prone scan should be done, or if still in doubt, and it can be supplemented with an MR scan. Next is a case of advanced glottic malignancy with significant supra and infraglottic extension, metastatic pulmonary nodules, and hepatic metastasis. So if you see advanced hypopharyngeal or laryngeal disease, you should supplement the staging with at least non-contrast CT of the thorax, and if possible, a PET CECT. Now, what are the key imaging findings which we cross key imaging findings which will have impact on the management? So the first three are the pre-epiglottic, paraglottic space, and postcricoid region invasion. If you see any of these, the patient would be a candidate for multimodality, that is CTRT. If there's an early or inner cortex erosion of the thyroid lamina, it could still benefit with multimodal treatment, but there is no need for radical surgery. If there is destruction of both the cortices or there is exolaryngeal spread, then a patient is a candidate for total laryngectomy. If there is exolaryngeal, small volume exolaryngeal spread, no involvement of the cricoretinoid joint, and there is a if there is a possibility that patient functional may have a functional larynx after treatment, a trial induction chemotherapy can be given. If there's some response, then that couldn't be followed by definitive treatment. If there is significant exolaryngeal spread with prevertebral fascia involvement or circumferential carotid artery encasement, these are the candidates which are palliative and unresectable. Now, going much into the depth of individual findings on the CT or on MR, which can help in management, is where is the epicenter and what is the craniocaudal extent. That is very important for radiotherapy planning. At the same time, 3 dimensions and the volume of the disease also helps into RT planning and prognosis. So glottic disease less than 3.5 cc and supraglottic disease less than 6 cc have better outcomes than the other ones. So volumetric could be a guide to predict prognosis. Again, transglottic spread of the disease or spread into preepiglottic space, these are again the factors guarding the type of management the patient would receive. If there's anterior commissure involvement, it might look like an early T1, but it could be a T3 because you've missed a subtle cortical erosion or thyroid cartilage invasion. And in such cases, MR is quite helpful into accurate staging. Posterior commissure disease are contraindication for laser because and cricoretinoid joint involvement is also a contraindication for laser. Arytenoid sclerosis or destruction is a T4A disease, and subglottic extension, it limits the cricoid preserving surgeries. Hyoid bone invasion is quite rare, but it does influence the type of surgery the patient would undergo. And if there is extensive extracapsular spread or the planes are lost with carotid surgery, these are poor prognostic signs and patient would have early recurrences. Now, this is the comprehensive reporting template, which includes each and every possible finding, which automatically could give you the T stage, N stage, and M stage, and also will help you into planning the management of these patients. I think this is very well used in Tata. While I was there, we did develop this. So just to highlight what is cartilage imaging and which is the better one, is it the CT or the MRI? So while we can see that the sclerosis, which is the most common sign which we see on imaging, is not a very specific sign. Sclerosis can occur because of the contact of the tumor next to the cartilage. So as the tumor is in contact with the cartilage, there is hyperemia. And this hyperemia leads to a sclerosis. Now, this is a non-specific sign, but the sensitivity is quite high. It can go up to 83%. The other signs are lysis and erosions or laryngeal spread. So these are specific signs, but their occurrence is within the range of 64 to 44%. So the transmural exolaryngeal spread is approximately, the CT is 44%, is seen in 44% of the cases, in advanced cases. And lysis is more common, which is seen up to 64% of the cases. Even normal ossification patterns can be misleading, such as sclerosis of age-related sclerosis of the arytenoid, or there is sclerosis of the cricoid. And these are normal variants that should be kept in mind before documenting cartilage involvement. In patients under 40, the cartilage is normally not ossified, and that becomes a challenging situation. That what we call in radiology is the white line of the cartilage. You can see that the predominant bulk of the cartilage is not ossified, and in such cases, one must supplement a limited MR to rule out any finding which could preclude CTRT or function preserving surgeries. So as seen in this case, the first case, we see that the white line of the cartilage is there, and we supplemented this with MRI, and you can see extensive paraglottic space involvement. However, the paraglottic space was looking somewhat fine in the CT scan. Compared to the other case where we see the white line of the cartilage, look at the MR with the extensive exolaryngeal spread, which was not appreciated on the CT scan. So this is the advantage in these cases. It's these subtle findings may be missed in patients who have white line of the cartilage or unossified cartilage. It's always also good to go back and review the PET-CT if available to see if there was any exolaryngeal spread which was missed on the CT scan if you've done a contrast enhanced PET-CT along with, contrast enhanced CT along with PET. So the PET component can suggest that there is exolaryngeal uptake, which is suggestive of exolaryngeal spread. Sometimes we get patients referred from another hospital, and we have a time interval between the scan and the follow-up scan by the time patient has reached us. So remember, in anterior commissure disease, the review shouldn't happen in patients who have had scans more than 4 weeks, because these small volume disease can be very notorious to involve the cartilage early. So if you have a scan which is more than 4 weeks old, always request a fresh scan to stage the disease. And as shown in this case, this is a scan delay of around 6 weeks, and you can see the volume of the disease, even though has marginally increased, but there's cortical erosion and destruction of the cartilage by the time patient was rescanned. So with that, this is my final slides, that radiologist definitely plays an important role in multidisciplinary selection of the treatment options. It's very important that you select your cross-sectional imaging appropriately and supplement with MR if needed, and which gives you the tumor volume, the extension, and the spread, which does make an impact on the management and treatment options. And it's also very important that the reporting radiologist should be aware of the standardized protocols, the familiarity with the key anatomical structures, and also the patterns of spread, which is fundamental for interpretation. If there are any questions, I'm happy to take, and most of the cases are from this article with the spread patterns. If anyone would like to read further, I would suggest this one. Thank you.
Thank you, sir, for the informative talk. Now we will move on to our next session, that is on case discussion. And for that, we have with us Dr. Anil D. Cruz. He's a director of oncology, Apollo Hospitals, Mumbai, Delhi, and Chennai. We have Dr. Sarbani Ghosh Lashkar. She is professor, radiation oncology, TMH, Mumbai. We have Dr. Krishna Kumar Thankapan, professor, head and neck oncology, Amrita Hospitals, Cochin. And we have Dr. Ratan Shetty, associate professor, Department of Head and Neck Oncology, ACTREC, Mumbai. Welcome, everyone. And today's case presentation will be on carcinoma larynx, and it will be presented by Dr. Labdi Nirmal. And yes, you can proceed. You can share your screen now.
Good evening. At the outset, I would like to wish a very happy Teachers' Day to all my teachers. Is my screen visible?
Yes, it's visible.
Can I begin?
Yes, you can start. You can begin.
So today I'm presenting a case of a 52-year-old male who was a resident of Madhya Pradesh, a taxi driver by occupation. The history is given by the patient himself. The patient presented to our OPD with chief complaints of change in voice since 1 year and breathing difficulty on exertion since 2 months. Patient was asymptomatic 1 year back when he started developing a change in his voice, which was insidious in onset, gradually progressive, hoarse in nature. It was persistent throughout the day, worsened over the last 2 months. The patient also gives history of breathing difficulty on exertion since the last 2 months, which is relieved at rest. It is associated with intermittent cough since the last 2 months. There's no history of cough particularly associated with swallowing. There's no history of difficulty in swallowing. There is no history of any noisy breathing, any pain associated with the swelling. There is no history of any foreign body sensation in the throat. There's no history of blood and sputum or any neck swelling. There's no history of vocal abuse or weight loss. Coming to the previous treatment history, Patient had a history of vocal cord biopsy 6 months back at a local hospital in his hometown, which was suggestive of a severe dysplasia, but the patient did not take any treatment after that. Coming to his addiction history, the patient gives history of tobacco consumption. He is a BD smoker, smokes 1 pack per day since the last 20 years, and he has reformed since the last 6 months. There's no history of alcohol consumption or tobacco chewing. Coming to the past history, there's no history of any comorbidities or surgeries in the past. His personal history, patient has a good appetite and undisturbed sleep. He consumes a mixed diet and has normal bowel bladder habits. The patient is married with 2 children. The family history was not significant. So to summarize on history, my patient is a 52-year-old male, BD smoker, 1 pack per day for the last 20 years, recently reformed, with progressive hoarseness of voice since 1 year and breathing difficulty on exertion since 2 months. Can I continue with the examination?
Labdi, KK here.
Yes, sir.
Who all are there with me? Sarbani is there, is it? Sarbani?
Yes, yes, I'm here. I'm here.
And Recruiter is there.
I'm there as well.
Sir.
Yeah, I'm also
Okay.
here. Good evening, sir, and happy Teachers' Day to AKD sir, PK sir, and Sabani madam.
Thank you, Ratan.
Okay, Recruiter, do you want to start?
No, go ahead, KK.
I'll just ask a simple question. What do you think happening here, Labdi, from the history?
So this patient has a lesion. He has presented with voice complaints, which has progressively worsened, and he's recently developed dyspnea on exertion as well. So I'm suspecting a malignant neoplasm involving the glottis. Since the patient presented to us with a voice change first, and there's no history of any foreign body sensation in the throat or dysphagia.
So why do you say it is malignancy?
See, because his symptoms have progressed over the last 1 year, and there is dyspnea on exertion as well. So there is some lesion which is progressively increasing, which is precipitating these complaints.
How do you explain the dyspnea?
So it could be because of vocal cord involvement and fixity, or a growth into reduction in the glottic chink that could be causing dyspnea on exertion, but he doesn't have it on at rest.
Okay. Is there any cough while eating or drinking?
No, sir, not particularly. He's just having intermittent cough. It is not associated with swallowing.
Right, and no pain.
No pain, sir.
Okay, and what would have caused this problem?
So it could be irritation because of the mass that is causing intermittent cough.
No, what is the etiology? I mean, how did this develop?
So the patient is has given history of smoking. He's a BD smoker, smokes 1 pack per day for the last 20 years. So that could point towards a malignancy. Etiology.
How will you correlate BD with this problem? What is there in BD?
So tobacco. So tobacco smoke can cause, it contains polycyclic aromatic hydrocarbons, nitrosamines, and it can get dissolved in saliva and can cause cancer, or it can get deposited on the epithelium of the vocal cords during smoking, and the local enzymes can cause formation of epoxides, which can cause which can cause DNA damage and RNA damage, leading to formation of DNA adjunct, and further lead to decreased apoptosis, increased angioneogenesis, and proliferation.
All right. Is this patient takes alcohol frequently?
No, sir. No history of alcohol consumption.
All right, go ahead.
Okay.
How do you know that there is no chest pathology that is causing all these symptoms?
Ma'am, the patient has presented primarily with a voice change and not a dyspnea. And there is also no hemoptysis. Hence,
Can voice change happen because of a lung pathology?
yes, ma'am, it can, but that if the recurrent laryngeal nerve is involved by a lung pathology, it can happen.
So you need to be aware of that, because now it looks like as if you know this patient has got a laryngeal tumor. Of course, you would know it because you've done the examination, but I think it is important for you to keep that your mind open about the lung pathology also.
Right. Yes, ma'am.
Don't get scared. You're presenting well. When the examiner asks you, is it lungs, say that the patient does not have cough as the predominant system, doesn't have hemoptysis, and has come only with hoarseness. In advanced lung, you will have hoarseness, and that will have symptoms which are predominantly chest. So you're doing well, and you can answer the examiner. You put the points, but be forceful when you present.
Yes.
Go ahead. And also, this patient had some history of some dysplasia on a biopsy earlier, right?
Yes, sir. It was
So
severe
why?
dysphagia. Yes, sir.
So
So you,
why aren't you saying that? You say he has got a lesion on the cord which has been treated earlier, and that's why my diagnosis is to do with this. How quickly does dysplasia manifest with advanced cancer?
So
sorry,
depending on the
Labdi,
grade of
1 minute, Labdi,
dysplasia,
1 minute. Sunaina, can we mute all the people who are not speaking because it's disturbing the whole thing?
Everybody is actually muted. It is from one of the backgrounds. I don't know.
Labdi, go ahead, please. Sir is asking a question. Please go ahead.
So when was the dysplasia diagnosed?
6 months back, he underwent a biopsy at his local hometown that was suggestive of severe dysplasia.
So does it explain that can dysplasia become into an advanced glottic cancer in 6 months?
So actually, it depends on the grade of dysplasia also. So mild dysplasia is shown to have a malignant conversion rate of 0 to
Okay.
11%. For
Even if
severe,
it's a severe, even if it's a severe dysplasia, will you get dyspnea within 6 months?
unlikely, so it takes several years
So
for the malignant
very,
transformation.
maybe several months as well. So what is the most likely diagnosis that you got a dysplasia and now you have an advanced cancer? I just want to understand your thinking.
So probably it was a superficial biopsy or not a very representative biopsy.
Absolutely. Absolutely. So the biopsy was not done properly at the advance. Okay, great. Go ahead.
On examination,
I do have a question. I do have a question. What
Yes.
are the mode of biopsy? What did they use? Did they do a DL scopy biopsy or ML scopy biopsy? Do you have any information regarding that?
No, sir. So the patient did not have any papers from his previous biopsy. He just was having a biopsy report.
Yeah. Thank you.
Coming to the general examination, the patient is conscious, cooperative, well-oriented. He's moderately built and well-nourished. The performance status of the patient is ECOG 0. Patient is vitally stable. He's afebrile and saturation is 99% on room air. There is no stridor, no pallor, icterus, cyanosis, clubbing, edema, or generalized lymphadenopathy. The systemic examination is also grossly normal. Coming to the local examination, on inspection, there is no neck swelling. The larynx and trachea appear central. There is no laryngeal widening that is evident. The skin is normal over the neck, and the oral cavity oropharynx examination are normal, and tongue movements are also normal. The inspectory findings are confirmed on palpation, and additionally, laryngeal crepitus is present. We've done a fiber optic laryngoscopy for the patient. The findings I'll be showing. On fiber optic laryngoscopy, we can see there is an ulcer-proliferative growth epicentered over the right true vocal cord, which is involving the entire vocal cord from the anterior commissure just short of the posterior commissure. It is also crossing, probably involving the contralateral, the left true vocal cord, crossing through the anterior commissure, involving the anterior part. There's also superiorly extension into the false cord. And we can also see that there is some subglottic extension as well inferiorly. The right vocal cord is fixed and the left cord is mobile, although the arytenoid has some mobility on the right side. The rest of the examination is normal. The AE folds, the bilateral piriform fossa sinus, the epiglottis, bilateral vallecula, base of tongue, they are all normal.
Lovely. Quickly explain us what you mean by laryngeal crepitus and why is it lost?
So laryngeal crepitus is a sign when the cricoid cartilage rubs against the vertebral column, which is normally seen in everybody. But when the postcricoid surface is involved, or when the posterior pharyngeal wall is involved, prevertebral fascia is involved, this sign can be lost. So it is suggestive of either advanced disease or postcricoid disease.
It used to be a valuable sign before the era of CT and MR, but now with that it's lost its importance. But it does show laryngeal fixity and a sign of exolaryngeal spread. Explain me why you said that the cord is mobile. I mean, the cord is fixed and the arytenoid is mobile. How does that happen?
So the cord can be fixed because of extensive paraglottic space involvement because of the bulk of the tumor. But the cricoarytenoid unit can be not be involved, and hence the arytenoid is cricoarytenoid joint could be free, and hence the arytenoid is mobile.
What is the implication when making a treatment decision?
When the cricoarytenoid unit is functional, we can opt for conservation laryngeal procedures as well.
Yeah, so basically you should say if the arytenoid is fixed, it's unlikely that you would do any conservative procedure. Okay, go ahead.
So to summarize, my patient is a 52-year-old male smoker with a history of change in voice since 1 year and breathing difficulty on exertion since 2 months, with an ulceroproliferative growth epicentered over the right vocal cord with subglottic extension and fixity of the right cord, most likely a malignant neoplasm of the right vocal cord.
There's one extra sign that I like nowadays for my residents to present to me. How do you know if the larynx is dysfunctional?
So during the FOL only, we can do a fees as well to know whether there is and look for any penetration or aspiration. And hence we will know whether the larynx is dysfunctional or not. Also, if fiber optic laryngoscopy is not available, we can do a modified water swallow that can give us an idea about.
No, you're going too fancy. If you had told me 2 signs, I would know that you're very comfortable. One, this patient is complaining of dyspnea. I would have liked
Yes.
you to tell me in your I would have liked you to tell me in your presentation,
Yes,
because
sir.
if it's
Hello.
not adequate, hello, can you
Yes,
hear
sir.
me? Yeah, you must
Yes.
tell us about the laryngeal editus. Patient is complaining of dyspnea. If the patient has a compromised laryngeal editus, radiotherapy will be a problem in the beginning. And second, if there's any pooling of saliva. So you could end your examination by saying the larynx looks functional, editus is okay, and there's no pooling of saliva. May not be very appropriate for a glottic cancer, but for laryngeal cancers in general.
Yes, sir.
Okay, KK, Sarmani, Ratan.
Yeah, Labdeep, what is this dysfunctional larynx? What are the functions of larynx?
So the functions of larynx are maintenance of airway, breathing, protection of the airway, phonation, and it also plays a role in swallowing.
So how do you?
But dysfunctional larynx is when the patient is either a tracheostomy tube dependent or feeding tube dependent. And there is significant aspiration on eating meals.
What do you mean by significant aspiration? I'm a little confused with this.
No, aspiration, I would say.
Labdeep,
Is there? Yeah, go ahead.
how sensitive is water swallow test in detecting aspiration?
So it's in cases where there is silent aspiration, it is not very sensitive, but it is a good bedside procedure to assess for aspiration.
What is silent aspiration?
So silent aspiration is when there is aspiration of saliva, continuous aspiration of the saliva, and the patient presents with aspiration pneumonitis, but there is no history of there's no history suggestive of any aspiration, where, especially patients don't give history of cough on swallowing food.
So how does that happen? Is it very common in malignancies?
So there can be decreased sensation because of involvement of the superior laryngeal nerve, the internal branch especially, which can precipitate, which can lead to the patient not realizing, and there can be silent aspiration.
Yeah, so that's silent aspiration is when aspirates, but because of the sensation, he may not be absence of sensation, he may not be coughing. Usually that happens with some neurological problems. Of course, it can happen in malignancies too.
Labdeep,
Yes, ma'am.
Labdeep, what is penetration?
Ma'am, penetration is when the material enters the airway, but it does not cross the vocal fold.
I believe if it crosses the vocal cord fold, it is called penetration.
Sure. And
No,
is that also a sign of dysfunction?
Uh,
Do you always look only for aspiration, overt aspiration, or do you look for penetration and pooling also?
Ma'am, we do look for penetration and pooling also, but aspiration is a sure sign of dysfunction.
Yeah. So in your pass scale, where will penetration come?
So pass scale 2 to 5 is when penetration will be there, but there is no aspiration. And 6 to 8 is when we see that there is aspiration.
Beyond
So
6
can you?
aspiration.
Yeah. Well, I think Ratan, go ahead.
Yeah, beyond 6 is aspiration, up to 5 touching the vocal cords. And if
Yes.
it enters the laryngeal introitus, it is penetration.
Penetration. Yeah, okay. Labdi, can you just list out all the dysphagia aspiration related structures?
Ma'am, the constrictors, the supraglottis and the glottis.
Else that you've missed out? What happens to the base of tongue and what about the upper esophageal sphincter?
Yes, ma'am.
So this is the whole list. It's the constrictors. It is the base of the tongue. It is your thing, or what you call the upper sphincter. All these structures, that is all your central structures, will together contribute to the dysphagia and aspiration. So you need to know them, and that is what is assessed during all your assessments.
Okay, Labdi, hello.
Yes, sir.
So, what is the stage of your case?
So clinically, it is a T3 and above lesion, but I would like to do a radiological assessment to correctly
T3?
grade to stage.
Agreed. T3 what? I mean, no, complete, you tell me the whole,
So
the complete
T3
staging.
N0 clinically, because at least T3 N0 clinically.
T3 N0. Malignancy of the vocal cord.
Yes.
Okay, so why do you say it is T3?
So because of fixity of the right cord, I would call it a T3 tumor.
When will you qualify it as T4?
So when there is exolaryngeal spread, either through the cartilage or through the soft tissue involving, or there's involvement of the soft tissue, the trachea, the soft tissues of the neck, including the thyroid gland, then the strap muscles, the esophagus, the extrinsic muscles of the tongue.
Okay. And T4B?
T4B is when there is advanced disease encasing the carotids, involvement of the prevertebral fascia or extension into the mediastinum.
Right. What is a transglottic tumor?
So transglottic tumor is when the tumor involves more than one subsite, the supraglottis, the glottis, or with subglottic extension as well.
Okay. So
Well,
what is the...
KK, is that a correct answer?
I don't fully agree, but yeah. I think it's when
I
a
don't
tumor...
understand.
Yeah.
I thought when it crosses the ventricle, a
Ventricle,
glottis crosses the ventricle and goes to supraglottis, or supraglottis comes across the ventricle into the glottis, it's transglottic. At least, I don't know, Ratan and Sharbani, just correct me.
Any tumor which crosses the ventricle is called a transglottic tumor, either
Yeah,
from
so
middle
this,
upwards or above
yeah.
downwards.
No, she said something about subglottic spread and all. That's why I got a little troubled.
Any tumor which crosses the ventricles from vocal cords to the supraglottis or from supraglottis to the vocal cords is called a transglottic tumor.
That's it. So, lovely, please, no subglottic business, huh? KK
Yes.
is a kind examiner.
Yeah.
Okay.
Okay, Labdi, what are you going to do about this?
So I would like to get an imaging to correctly stage the tumor.
What imaging?
So I would like to do a contrast enhanced CT scan of the neck and thorax
What
with
is...
the 1 mm cuts.
Okay, what is the purpose of doing that?
To know the extent of the disease, also to plan the resection, to decide whether the patient is operable, to look for any nodal disease, and to see if there are any distant metastases. So planning of management.
Again, I want a little clarification. You want 1 millimeter cuts all the way from the top of the larynx to the mediastinum, is it? You just said that I'll do a CT scan from top to mediastinum with 1 millimeter cuts. I don't know if Abhishek is there. Abhishek? Go ahead. Would you like to clarify, Lovely? Do you want 1 millimeter? Why do you do 1 millimeter cuts? And where do you do 1 millimeter cuts?
So they give a better resolution when it comes to the larynx, laryngeal framework.
Again,
No, but
no, go ahead, Sarvani.
so Labdi, in this case, you've got a tumor which you think is at least a T3. Now, in this kind of a tumor, do you want 1 millimeter cuts? Because what additional information with your 1 millimeter do? Now, here essentially you want to look at the extent of disease, know about the extent of disease, know whether this patient will or will not be a candidate for organ preservation. So, what are you interested in looking at? So that is why a 1 millimeter cut today may be a little too much. You may actually do what you call a reformatting after you've taken the cuts. We don't do 1 millimeter cuts.
For an advanced glottis, so for an early glottic cancer, I would agree with you that you do a 1 millimeter cut and predominantly at the level of the glottis. You want to see the extent of spread. But in a large advanced cancer, it's not mandatory. And in one breath, you said I'll do up to mediastinum at 1 millimeter cuts. That's why I felt it was a little too much.
Labdi, what is the anatomical dimension of vocal cords?
Uh,
Or from what level? You don't have to tell the size. How do you define vocal cords? What level? From what level to what level it forms the vocal cords?
so
Same thing
the
for this also, please. That also be your answer.
sorry.
In addition to the glottic larynx, also
So from the superior surface of the true vocal cord till 1 centimeter below that is the
Again,
glottic larynx.
not very sure that the answer is correct. Huh?
is not.
Yeah, I'm not able to hear you clearly, Labdi. Could you please come again?
So from the superior surface of the true vocal cord till 1 centimeter below it is the glottic larynx.
Is 1 centimeter anterior, posterior? Where is the
Inferior,
subglottis?
inferior.
Yeah. But does it vary? Where does the subglottis start? Below the vocal cord anteriorly, and is there a difference posteriorly?
The reason for that?
Yes. So because of the signature shape of the cricoid.
Okay. Listen, Labdi, I'll tell you. The subglottis is 1 centimeter below the true vocal cord anteriorly and posteriorly 0.5. Explain what's the importance and why does this happen?
It is because of the signature shape of the cricoid cartilage that anterior.
Okay, good. And what's the importance when making choice of treatment?
So patients with subglottic extension of the tumor are not suitable candidates for organ conservation surgery, and also patients with subglottic extension.
Listen, I'm asking about 1 and 0.5. So when you evaluate a patient for conservative larynx, you
Hello.
hello.
Hello. Yes, sir.
Yeah. So when you have larynx, you may be able to do a conservative larynx with up to 1 centimeter of spread anteriorly, but posteriorly, it will come onto the cricoid. So minimal spread beyond 5 millimeters will not allow you to do a conservative procedure.
Yes, sir.
And I think again I stand correct, Ratan and all. You divide supraglottis, glottis, and subglottis by this line 1 centimeter, 5 millimeters between glottis, and the glottic region starts at the ventricle, in the middle of the ventricle. Everything below that, if you draw an imaginary line across the ventricle, below that is the glottis.
Sir, your voice is a little bit.
I'm in a car. Okay, go ahead. No problem. And last point on anatomy, how do you surface mark the anatomy of the vocal cord from outside? If you're doing a conservative larynx, where will the cord be when you're making a cut on the thyroid cartilage outside?
Sorry.
Hello?
And does it change with the gender of the patient?
No, you can't give clues, man. Ratan, is she from Tata, is this girl?
Yes,
Yes.
sir.
Yes.
That's why I can make out you're an internal examiner.
Sorry.
Okay, go ahead. It's a good clue. It's a good clue. Go ahead.
Okay, you said CT scan. Why not MRI?
So CT scan, because we have a faster acquisition. Also, it is we can get high resolution images. Motion artifact is not there. It is more easily available, and it is less time consuming.
All right. So what exactly in
Also,
this?
we can check the lung. We can do thorax imaging along with at one go itself.
Right. Okay. And what exactly in terms of extent of the disease will you be looking in the CT scan? What will you look?
So whether there is what is the superior all the superior, inferior, and lateral extent of the disease, whether there is
Means
cricoarytenoid superiorly, whether the base of the tongue is involved, inferiorly, whether how much is the subglottic extension,
so probably in
whether
this case subglottis. I don't think this tumor is going to the will go to the base tongue, right?
yes, sir.
Okay. So
There
maybe
is
it can
look
extend to
at the
the
pre-epiglottic, whether there is pre-epiglottic space involvement, whether it's invasion of the cartilage and exolaryngeal spread
and
and
subglottic
involvement
invasion.
and
Okay.
subglottic.
So you might have heard from Abhishek. So what are the CT criteria for cartilage involvement?
So we look for if there is any whether there is any sclerosis or lysis or erosion or transcartilaginous spread.
Extralaryngeal spread.
Yes, sir.
Which among this is most sensitive?
Sclerosis is the most sensitive.
And most specific?
Most specific is erosion, lysis, and transcartilaginous spread.
And I'm asking one. Most specific.
The transcartilaginous spread.
Yeah. And but what is the problem with the extralaryngeal spread? It is less specific. I mean, it is less sensitive. It is seen only in up to 42 or
44% of the patients. Yes, sir.
so it is less sensitive. So we can't rely just on extralaryngeal spread. What are the MRI care and who gave this criteria?
I'm sorry, sir.
Okay, you will have to read it, I think. Okay.
Yes.
Okay, listen, let me jump in with a little prize-winning question. Sclerosis is one of the first signs to happen. How does sclerosis vary among thyroid, arytenoid, and cricoid cartilage? Does the sensitivity vary?
Yes, sir. So for the thyroid cartilage, the sensitivity is lower than that for cricoid and
And
there's
the
a paper on this.
arytenoid.
I'm sorry, yes, sir. There's a paper on this. I'm forgetting, so sorry.
The name of the lady who wrote this paper is called Minerva Becker. Have you read it?
So I've read the abstract. I'm sorry, I've not
Anyway,
read
no,
the paper.
anyway, no issue. Pretty good that you answered. That much is good enough. Okay, go ahead.
Sarbani madam or Ratan.
Yes, she can go ahead.
She can go ahead.
Okay, you're going to
I'd like
show us
to
the
bring
scan, is it?
Yes, sir.
Before you go ahead, one last question on evaluation of the larynx. What's the role of NBI in early laryngeal cancers? Since this is on laryngeal cancers.
Yes, sir. So, sir, NBI definitely has a role in early laryngeal cancers. NBI, there's an NBI grading given by Ni et al., which looks at capillary loops, intraepithelial capillary loops, and
No.
it is
1 minute.
graded
It's called IPCL, not intraepithelial. IPCL. What is intraepithelial? Yeah, capillary loops.
capillary
IPCL.
loops.
Yeah,
Yes, sir.
okay. Correct. Okay, go ahead.
Grade 4 and 5 are grades 1 to 3 suggest a benign lesion, whereas when we see when it is grade 4 and 5, it points towards malignancy, and NBI guided biopsies have a better yield as well. So.
Okay, good. It's not okay. Forget the grades. Is it the longitudinal capillary loops or vertical that are more dangerous?
The vertical ones.
Okay. You're using common sense or you read?
Mm.
Okay, go ahead.
Coming to the imaging of this patient. This is a contrast enhanced CT scan of the neck. And here we see the pre-epiglottic space coming into picture. We see the lesion appearing in the at the level of the false chord on the right side. As we go downwards further, the cricoid cartilage has started coming into picture, and the cricoarytenoid joint now.
No, 1 minute. Where is? Okay, fine. Okay.
So we can see the lesion on the right side. This is at the level of the cricoid, and there is a transcartilaginous spread anteriorly. There is also some degree of subglottic extension that we see. The thyroid gland appears free, and there are some small subcentimeter lymph nodes that are seen.
So what levels of lymph nodes will you see?
So I would see level 2, 3, and 4 lymph
That's all? That's all?
for advanced laryngeal cancers.
That's all?
Now with subglottic extension, what other level will you want to look at?
Paratracheal involvement is paratracheal nodes as well.
Central compartment lymph nodes.
So central is level 6.
Level 6, yes.
So when will you look for level 6 nodes in laryngohypopharyngeal cancers?
So when there is a subglottic extension, when there is in hypopharyngeal primaries, because
Specifically, which primaries?
piriform fossa sinus tumors.
Which part of the piriform sinus?
When the apex is involved.
Yeah, and
there is exolaryngeal spread, and also high grade or T3, T4 glottic tumors.
And
Madam wants one more subsite.
Subsite of hypopharynx.
Post-cricoid.
Yeah, somebody has
When will
asked.
you look for, yeah, when will you look for retropharyngeal lymph nodes?
In post-cricoid malignancies.
And
Uh,
what are the subsites of the hypopharynx?
Posterior pharyngeal wall.
Yeah. Go ahead. So then this is what. So can you tell us the CT criteria for pathological lymph nodes?
Ma'am, loss of fatty hilum, central necrosis, and the size and the shape of the lymph nodes, more than 1.5 centimeters, and rounded lymph nodes.
Okay. And what greater, taller, greater than thing, wider, or what is it?
Ma'am, rounded lymph nodes.
So you said the size, the shape, the presence of central necrosis, and
whether there is any exolaryngeal
laryngeal spread.
extra
So there is any,
nodal extension.
yeah. So that means if you've got any matted lymph nodes or lymph node groups, right?
Yes, ma'am.
Yeah. Okay. What is the final stage of this tumor?
This is a T4A N0 CA carcinoma right glottis.
Any other questions from anybody, or should we go with management?
Yeah, so you got the images, you got the staging. What is your next step?
Sir, I would like a biopsy
Mhm.
in this patient to establish the diagnosis.
Okay, how will you do that?
Sir, we can do a FOL guided biopsy, fiber optic laryngoscopy guided biopsy, or we can do a DL scopy biopsy. In this patient, particularly since there is a reduction in the glottic chink and it's a T4A, it's an advanced cancer, I would like to take consent of tracheostomy before I go ahead with the direct laryngoscopy. Or I can just do a fiber optic laryngoscopy guided biopsy.
All right. If it comes out to be
1 minute. Take a little vague here, the answers. Which one will you do on Monday and Wednesday? You'll do flexible and on other days DL. You have to tell us what you'll do. Examiners won't be kind. You have to tell what you'll do and why. Your answers are right. Your logic is right. But which one would you prefer?
So for this patient, since the hemilarynx is already fixed and we have already seen that transglottic exolaryngeal spread is present through the cartilage, so we know the staging of the tumor. So we can do an FOL guided biopsy as well to get the diagnosis, and we can do a
Tell
direct
me,
laryngoscopy.
1 minute. Tell me in Tatas, how many times have you all biopsied a glottic larynx with flexible scope? In your own practice, your examiner internal is sitting there. How many times do you do flexible biopsy for a glottic larynx?
So we have started doing flexible biopsies now.
For
Is it
glottic,
is it easy to do a glottic biopsy with a flexible scope? What happens when you put the biopsy forceps there or the through the biopsy port?
The patient starts coughing. It is.
then why did you start doing now? They stop coughing now, is it?
No, sir, actually,
And you have mentioned that the patient had dysplasia on the initial biopsy. So
yes.
would you still attempt a fiber optic laryngoscopy on this patient? In my book, I wouldn't do this. I would.
Even I wouldn't do it. But I like that you would take consent for a tracheostomy. That's absolutely well said.
okay, Labdi. So, what was your biopsy? Did you do it?
Lovely. 1 minute before you go, one last point which an examiner sometimes likes. when the patient has a compromised laryngeal editors, and if the patient had a node, you can say, sir, I'll avoid FNA. I would avoid a biopsy from the primary because I might precipitate a tracheostomy. I'm doing an FNAC from the node, establish the diagnosis of SCC, and I'll go ahead and treat my patient because I will not be able to get a glottic biopsy. I'm just giving you as an option. I'm not saying it's correct now, but just as an option. They may ask you.
Yes.
Go ahead.
Now
Do you
you've
have
got a histopathology of moderately differentiated carcinoma, squamous carcinoma on this pathology, on the biopsy that you've done from the glottic lesion. So next, what will you do?
Ma'am, this is a T4 tumor, T4A tumor. So I will counsel the patient for surgery as larynx preservation protocols. Patients don't do very well when given larynx.
Don't use words like that. Don't use terms like that. Don't do very well. Nahi. So what are your options of treatment for this T4A N0M0 glottic larynx?
Total laryngectomy, ma'am, with neck dissection, selective neck dissection, and primary closure with tracheoesophageal prosthesis.
Why will you not consider this patient for any form of organ preservation?
Ma'am, because patients with T4 lesions with cartilage erosion and exolaryngeal spread, the overall survival and disease-specific survival is lower in these cases.
So what are the options of
Preservation. And also there is feeding longer, there are chances of feeding tube dependence and tracheostomy and dysfunctional larynx post CTRT, post larynx preservation protocols. Also, the rate of salvage laryngectomy and recurrence or residual
1
disease.
minute, Labdi, you have to be, Labdi, 1 minute. Will you even consider doing any kind of organ preservation in this kind of a patient?
What are the options or different ways of doing organ preservation?
So we can give induction chemotherapy followed by.
Can you classify it? This is a clue. Surgical and non-surgical.
Yes.
Yeah.
So, Labdi, you are correct. So you have to just, I think I agree completely with Dr. De Cruz. You have to be very confident when you're answering. So, and you know the reasons why you're going to do something versus why not to do something. So now can you just talk about the options of treatment once again?
Yes, ma'am. So I would like to go for surgery as the first line of treatment in this patient. And I would like to offer the patient a total laryngectomy with the bilateral selective neck dissection and primary closure with the
Labdi, sorry.
voice
Madam is asking what are the options? Options, and then you can give your choice. What are the options?
Options are organ preservation and surgery, total laryngectomy. In organ
Pertaining to this
preservation, we
case,
have.
Labdi, madam wants what are the options for this case?
Do you think there are options?
Are there any options of organ preservation in this case?
The near total laryngectomy, but
Near total is
I
not
don't
a
know. I
preservation.
want my surgical colleagues to say whether near total is possible in this patient.
Even it is not possible, but even if it is possible, if the primary was smaller, it's still not considered a organ preservation surgery. It is not an organ preservation surgery.
Why? Ask her why.
Why is it not an organ preservation surgery, Labdi?
so because we are removing the entire larynx and there is a permanent tracheostoma.
Any procedure
Absolutely.
which end up with permanent tracheostoma is not a organ preservation procedure.
So do you consider an organ preservation surgery in this case?
No, sir.
Why not? You may be right, but why not?
Sir, because there is subglottic extension in this patient, and there is the exolaryngeal spread through the cartilage. So I will not consider this patient for any organ preservation procedure.
Okay, so what can you tell me the principles of organ preservation surgery?
So, the principles of organ preservation surgery is that it should not affect the survival and at the same time preserve the function.
I think you may have to read on that point.
Criteria for organ preservation surgeries.
Criteria for organ preservation surgery include limited disease T1, T2, or select T3 patients with functional cricoarytenoid unit and no subglottic extension, no involvement of the hyoid, and no exolaryngeal spread. Also, patient factors need to be considered, like the performance status of the patient, the age of the patient, the comorbidities, the pre-op
Lung, what about the lung?
lung function, pulmonary function. Patients who are smokers with COPD with a reduced pulmonary function don't do very well.
Okay, could we give this patient CTRT? You said because of exolaryngeal spread, you won't give. Am I correct?
Yes, sir.
Which was the landmark trial that did this CTRT? What's the trial called?
So the RTOG 9111 trial by Arlene.
Excellent. Okay, excellent. How many did they take any T4 cancers in this trial?
Yes, approximately 10% patients were T4 cancers.
But you are telling me that T4 is not suitable.
So they found that T4 cancers post CTRT, the survival, the 5-year and 10-year survival was not very good, and 30% of the patients had to go for salvage laryngectomy after. So
Wa-
the primary purpose
wa-
of larynx preservation was not served.
Was the T4 cancers those with cartilage erosion, or they defined T4 as something else in the trial?
Sir, actually, the AJCC 5th edition was used at that time. So even minimal cartilage erosion was considered a T4 tumor. Inner cortex of cartilage erosion was considered a T4 tumor, which is not.
In my understanding, Sarbani is the pundit. It is cancers that involve the base tongue less than 1 centimeter in diameter. T4 were on the RTOG trial. It had nothing to do with the cartilage erosion.
With cartilage erosion, yeah.
Am I correct, Sarbani?
Yes.
Yes, sir.
So I'm not getting Alzheimer's yet. Okay, go ahead. So you should know that, lovely. 10% was an absolutely correct number, but they took minimal involvement of base tongue as T4 in that study. It had nothing to do with cartilage erosion. This thing about T3, T4 and inner perichondrium came through this and subsequently. Okay, go ahead. Has she vanished?
No, sir.
Or are you checking whether the examiners are saying correctly? Are you looking at Google?
No, sir.
Okay, go ahead.
I'm sorry.
Continuing as to why you're suggesting surgery and not any form of organ conservation. So go ahead, Labdi. So you said why we can't do organ preservation surgeries.
Yes,
Why
ma'am.
would you not consider this patient from any form of non-surgical organ conservation also?
The same reason when we look at the RTOG trial, patients who underwent CTRT, T4 tumors, uh, they had dysfunctional larynx and had to undergo salvage total laryngectomy in 30% of the cases.
Ratan, can you please continue? I'm just in the lift.
Sorry. Labdi, go ahead. So, what is your line of management for this? You are planning surgery.
Yes, sir.
So, what incision will you take for this case?
So since this patient does not have a tracheostomy, I would like to take an apron incision with a separate incision for the tracheostoma.
Why do you want a separate incision?
Uh,
Again, I'm not sure I agree with you. You'll take an apron incision. If you take an apron incision, it'll be difficult to do a separate incision for tracheostoma. You have to take a transverse incision and then a separate incision for tracheostoma.
yes, sir. Transverse incision.
Okay, excellent. Why do you want a separate stoma incision?
So to avoid a tripointer and
Absolutely. That's it. Perfect answer. Because if there's a leak, it will break down and there will be problems. So to avoid that, you'll do a transverse and a separate incision. That's it. Go on.
yes, sir. So I would plan a transverse incision and a separate incision.
Excellent. What all do you do in a wide field laryngectomy?
Sir, in a wide field laryngectomy, we do a total laryngectomy with bilateral selective neck dissection.
Then finish.
Anything else?
What do you take out? How many straps do you take out? How many lobes of the thyroid do you take out? Do you take out the hyoid and the pre-epiglottic space?
Yes,
What
sir.
all does
Yes,
it
sir.
encompass?
Yes, sir. In a wide field laryngectomy, we do take out the hyoid and the pre-epiglottic space as well. And if in T3, T4 tumors with subglottic extension, there is around 10 to 17% risk of involvement of the thyroid lobe. So I would like to take out the ipsilateral thyroid as well and ipsilateral paratracheal lymph nodes as well.
Lovely. So only ipsilateral paratracheal lymph nodes. What
Yes.
happens when you have subglottic spread? Does it go ipsilateral or
Yes, sir. It can go bilaterally.
then you're doing ipsilateral? Then Ratan will salvage, is it? Parastomal recurrence?
There is no role of ipsilateral in when subglottis is involved. Central compartment is not divided into ipsilateral and contralateral. It's a single compartment between two carotids.
Okay.
If subglottis is involved, you do a paratracheal clearance on either side, including
Yes, sir.
pretracheal nodes. Remember this.
Yes, sir.
So how will you decide on the reconstruction?
Sir, I would like to, I will measure the redundant mucosa, the remnant mucosa. I would, the supported mucosa, and at 3 levels, at the level of the base tongue, at the level of the cricopharynx, and at the narrowest point in the middle. And if the remnant mucosa is unstretched mucosa is more than 2.5 centimeters, stretched mucosa is more than 2.5 centimeters, then and unstretched more than 1.5 centimeters, then I can go ahead with primary closure of the pharynx.
So where at what level? You said 3 levels. So we stretching and unstretching. At what level will you do? What?
So the narrowest, the cricopharynx.
Cricopharynx or cricopharynx may be intact, right?
Yes,
If
sir.
you're considering patch.
Yes, sir.
So need not be cricopharynx. It may be somewhere in the middle area where it is narrowest. Okay, and then
No, but how often in glottic cancers will you have to have a reconstruction? Endolaryngeal disease into the
Not,
laryngeal editors. Huh?
so in the per primum setting, not so.
So this is what per primum.
Yes, sir. Yes, sir.
So you should have told KK that, sir, I'll close it primarily. It's unlikely that I'm going to have loss of pyriform. I'm saving both the pyriforms and I'm going to close this primary. Do you close a glottic cancer horizontal or vertical?
So we can close it vertically, horizontally, as well as T-shaped closure.
Which is the best
So
and why?
horizontal closure and T-shaped closure are supposed to be, our literature suggests that they are the best. A vertical closure is associated with pseudodiverticulum formation, more chances of pharyngocutaneous fistulas and leak.
What about dysphagia post-operatively?
Dysphagia as well. Yes, sir. Dysphagia is also, there's increased risk with vertical closure.
The commonest complication after a laryngectomy is dysphagia because voice you have rehabilitated in the acute, in the chronic. That's why you want to close them horizontal when possible. Okay, you can go back to KK's question on measuring. If you had to take out part of the hypopharynx, then how do you measure where and how do you decide on a slab? KK, you can take over.
Yeah. I think she answered it. What I was telling is, if at all you want to check the deficiency, you have to check it at the narrowest level, which is at the mid level usually. Okay, how will you speech rehabilitate this patient? What are the options?
So there is a primary as well as secondary. So there are, we can give the patient options for tracheoesophageal speech, esophageal speech, and electrolarynx. We can counsel the patient preoperatively. In this patient, we can do an intra-op TEP, or we can also plan the patient for a secondary TEP.
Which will you prefer?
So intra-op is
Why?
Hmm.
Do it late. Why you want to do primary?
so we can do it late also.
Hey,
Should have
no.
any choice, Labdi, doing
Yes,
it primary or secondary TP?
so we are doing primary TP.
So that should be your answer.
No, but why is primary preferred to secondary?
Do you know anything about time to voicing in primary versus secondary?
Yes, the time to voicing is shorter in
How short?
primary. 1 month. Not sure, sir.
You need to read about this.
And also the success of TE puncture is more if you have a primary puncture because the patient is more motivated than subsequent to radiotherapy. If you were doing a TE puncture, would you do any additional procedure on this patient surgically?
Yes, sir, I would do a cricopharyngeal myotomy in this patient.
If I wanted to do a pharyngeal neurectomy, would that be okay or should I do a myotomy?
So pharyngeal neurectomy is also an option, but the contralateral pharyngeal plexus can be supplying the cricopharyngeus, and also there can be branches of from the recurrent laryngeal nerve that can be supplying the cricopharyngeus. So there are chances of cricoesophageal spasm after neurectomy, which if we do a cricopharyngeal myotomy are lesser.
So why do you want to do cricopharyngeal myotomy?
So to get a vibratory segment which will help in vocalization.
What are the parts of the cricopharyngeus muscle?
So there is circular and longitudinal.
Does it have longitudinal?
So tell me again, why do you want to do cricopharyngeal myotomy? I didn't get it. You tell it is for vibration.
No, so there'll be a vibratory segment which will help in vocalizing.
That is always there, but why do you want to do cricopharyngeal myotomy for that?
So because if there is spasm at the
So you want to prevent a
prevent
cricopharyngeal?
yes, so prevent spasm.
Why do you want to prevent a
The
cricopharyngeal spasm?
esophageal. So it
Two
will
reasons.
yes, 2 reasons for voice and for swallowing.
Yes.
So how does it affect swallowing?
So there can be it can lead to dysphagia in especially post CTRT, post adjuvant treatment.
Now, what happens when in a normal individual, what happens to the cricopharyngeal muscle when he swallows? What happens physiologically? How does it relax?
When the bolus reaches the
When the larynx elevates.
elevate.
Larynx is removed now. The larynx won't elevate.
Yes,
So you
sir.
don't have the patient should not have a circular muscle fiber at that level. That's the reason why you do a cricopharyngeal myotomy. Doesn't actively there is no active movement from the larynx now.
Yes.
Okay, so you want to do a tracheoesophageal puncture, you say?
Yes.
You're saying?
Yes, sir.
So what all material will you order?
Sir, a grade 2 Provox, Provox, tracheoesophageal prosthesis.
So so suppose you are calling for a Provox prosthesis. What all dimensions will you think about?
So usually we use an 8 mm 17 French processes. The 8 mm is the length of the processes, and the 17 French is the diameter of the processes.
So why do you prefer these dimensions?
So the tracheoesophageal party wall is around 6 to 8 mm, 6 to 8 mm in our population. So and also it also accounts for some post-operative edema and post adjuvant treatment edema as well.
Okay. Good. Yeah. Can you enumerate some problems associated with TB?
Yes, sir. They can be
What percentage of patients in your practice develop speech or voice with TB?
So for TEP, it is important that the dimensions of the stoma are adequate, at least 1.5 centimeters, and the patient should be able to occlude it with a thumb. The patient should be dexterous, and also the cricopharyngeal myotomy is important for vibratory segment to produce voice.
What proportion of patients develop voice when you do a TP, tracheoesophageal processes, indwelling processes? Is it 100%?
No, sir.
What are the causes for non-voicing patient?
Sir, a patient with cricopharyngeal pharyngoesophageal segment spasm can be one of the causes. A patient is not motivated. There can be leaks in the TP, central or peripheral leak. That could be the cause.
The central or peripheral leak will not cause non-voicing. What are the causes for non-voicing? A patient who has been voicing for a year comes back and says that I'm not able to speak since 2 weeks. What will you suspect?
Could the prostheses have failed?
Yes, sir. So there could be some infection or candida infection or
What is siphon effect? What is pistoning?
pistoning. So pistoning is when the length of the pistoning happens when the length of the processes is more than the tracheoesophageal party wall.
Will cause TP leak.
Yes, sir. It will cause peri-TB leak.
So what happens when there is candida infection? How does the valve fail?
So there can be biofilm formation, and there can be because of the growth of the candida, there can be a mechanical obstruction as well that can cause.
And siphon effect. The TP may leak also.
Yes, sir.
The inadequate closure of the valve.
Sarbani madam, any questions? Maybe we'll go to. So you have done the surgery. What you are getting pathology report? What will you look in that report?
Sir, I would like to look at the margins, the nodal status, the differentiation of the tumor.
So, Labdi, when you're talking about pathology, it is always good to go in an orderly manner, because
ma'am.
then it will help you also decide whether you need adjuvant therapy or not. Now,
Yes, ma'am.
this was a T4A N0M0 by virtue of cartilage invasion. Will
Yes,
you
ma'am.
give it adjuvant therapy any which ways, or will
Yes,
you look
ma'am.
at the pathology?
I will give the patient adjuvant therapy.
Sure.
What are the tumor factors? What are the nodal factors?
So the tumor factors, margins, the grade of differentiation, the
Start
size
with
of
the
the tumor.
size. Start
Size.
with the size and the location of the tumor.
Yes, ma'am. The size of the tumor, the location of the tumor, hypopharyngeal tumors, then versus the glottic tumors, then the size, the differentiation, whether there is any perineural spread, any exolaryngeal
Lovely.
spread.
Labdi, wait, Labdi.
Wait. Where does size impact laryngeal post-op RT? Is it size or T stage? What
So it
size
is
you're saying?
no,
Madam
sir,
is
it is the
saying
T
size.
stage.
Then why you're saying size? You're saying you look at the size. What size you look at? 3 centimeters, 2 centimeters. It's the T stage in laryngeal and hypopharyngeal cancers. So all T3, T4 cancers will have it. Node positive will have it. You will add chemotherapy and 2 indications. Finished. Nothing else.
Yes, sir. For positive margins and extranodal extension.
Finished. What is great.
Labdi, what are the two types of margins in a laryngectomy specimen?
So two types of margins. So either positive margins or
Not like that. Not like that.
Mucosal margins and something else?
yes, sir. Mucosal margins and lateral margins, posterior margins,
Soft tissue mark.
soft tissue margins.
Poor girl, you're like confused. But I can tell you 2 more. I can tell you to look at the tracheal margin, the subglottic margin. There's so many margins you can see. So
What I wanted was the mucosal margin and a radial margin. Okay, so you have to see the radial margin. It means the surface, the soft tissue. Actually, it is a soft tissue.
Yeah, soft tissue.
Soft tissue margins.
Yeah, and the mucosal margins may be pharyngeal and tracheal. Okay, and that can be superior, inferior, lateral.
Yes, sir.
But KK, here also tracheal margin will be very important because this patient has subglottis. If you come very close on the tracheal margin, Sarbani will be a little more. generous on the fields, and she'll probably talk about it now, covering the storm. Sarmani, you want to say something?
Yeah, so that's what I wanted to ask you, Labdi. The tracheostoma that you create,
Yes, ma'am.
how important is it? And what about the stoma, manes, the things that Dr. De Cruz just spoke about on the histopathology? Why is all this important?
Ma'am, because these patients can have stomal recurrence.
If you have what?
Patients have closed margins or if paratracheal clearance is not adequate.
So what does the radiation oncologist have to do?
So, ma'am,
So for us, when we're doing the radiation therapy for patients, especially with hypopharyngeal cancers, and in this kind of a patient who's got subglottic extension, it is very important for us to cover the tracheostoma adequately. That means inferior coverage has to be adequate. Otherwise, you can get stomal recurrences, which of course, depending on the extent, would may be salvageable or non-salvageable. So we will have to take that into account when we see the histopathology report. And also because this patient also had a subglottic disease, we may also want to prophylactically cover the level 6 group of lymph nodes. And here actually the stomal size as well as your prosthesis that you've placed, they are also important considerations because as a result of radiotherapy, there may be peristomal reactions which can lead to narrowing of the stoma as well as the prosthesis. You'll have to look after it well.
Sarmani, would it be right to say you'll give 2 lateral fields and 1 anterior field covering the mediastinum as well?
So what we do nowadays is, of course, we're doing IMRT so that the anterior field question doesn't arise. But in the old days, we used to treat with APPA fields to cover the stoma adequately or make it a T-shaped field so that we go into the superior mediastinum a little bit so that we give adequate inferior margin to the stoma and then come off the cords at about 40 gray and then give bilateral off-chord fields to see that we are covering the stoma adequately. So you could either give bilateral off-chord lateral fields or you could give it with a little bit of an anterior angulation.
Yeah, but where are the cords here? When you say off cords means?
So off-chord meaning spinal cord, sir.
Spinal cord. Okay.
Yes, sir.
Spinal. Okay.
Yes, sir.
So, Labdi, since you have heard all this, to summarize, what are the risk factors of stomal recurrence and how will you prevent it? And if at all it happens, how will you manage it? What are the risk factors of stomal recurrence?
So for risk factors for stomal recurrence include closed margins in cases with subglottic extension. Then inadequate paratracheal clearance can also lead to stomal recurrence.
Anything to do with some procedure you do?
Tracheostomy.
Pre-operative tracheostomy.
Pre-operative tracheostomy cases also, if the clearance is not adequate, can have.
Does preoperative tracheostomy influence outcomes in laryngectomy? That is what sir wants to know.
Yeah, the position and the level at which you've done the tracheostomy in relation to the disease.
Yes, ma'am.
How does it make inferior? How does outcomes are inferior?
So tracheostomy can lead to inflammation and in the surrounding tissues and it leads to faster growth and spread of the tumor around the tracheostomy site.
Faster growth and spread of the tumor. Can you put it better? Does it cause faster growth of the primary?
No, sir. The spread is towards the.
What happens during tracheostomy? What is the cause for stomal recurrence?
So there can be, if there is subglottic extension, there are chances that we might even go through the tumor.
You will take margins. You have frozen.
And there are chances of, yes, sir, we'll be taking the margins on frozen.
So how will you manage if at all stomal recurrence happens?
So it depends on the grade of stomal recurrence. Stage it's given by Sisson et al. Stage 1 is when it is s- it is a focal recurrence in the superior stomal margin, which is not involving the esophagus. Grade 2 stomal recurrence is when the superior part of the superior half of the stoma is involved with involvement of the esophagus. These two stages are salvageable, but stage 3 and 4, when there is spread into the mediastinum anteriorly, which is stage 3 and 4 is below the clavicle, these may not be salvageable, sir.
Okay,
Type
good.
1, 2, 3, 4, right? Not grade.
Yes. Type 1, 2, 3, 4. Sorry.
All right, good. Sarbani, you want to take some questions on adjuvant?
Larynx, no adjuvant. Actually, there isn't much. But I thought and saw in the chat box, verrucous carcinoma of the larynx. How common is it? And what will you do there? Will you consider adjuvant therapy even in this kind of a patient?
Ma'am, again,
Again,
it will be dependent on the stage of the tumor rather
forget
than
it.
the
I don't think
histology.
it's not very common. It's not a very common histology in the larynx. And any which ways, if this was eroding the larynx and coming out T4, you may have considered it any which ways. Okay, now tell me something you know about why do you think the RTOG 91111 was such an important study? You talked about it some time back, but what is its relevance to today's understanding of organ conservation?
Ma'am, patient selection for
Okay, one thing is patient selection. So what did this trial tell you about doing CTRT or induction chemotherapy in patients vis-a-vis doing RT alone?
Ma'am, these patients had better larynx preservation rate as compared to RT alone, and they had better locoregional control as compared
But
to
then
RT
what
alone.
happened in this particular study? What happened? And that is when everybody became a little bit more conscious about things.
Ma'am, the long-term results by Arlene Foster et al. Again, they showed that 30.8% of the patients who had deaths due to unknown causes or
Very
causes
good.
not attributable to the cancer.
Okay. So what do you think those causes were?
Ma'am, it could be aspiration pneumonia, or it could be the chemotoxicities leading
So it
to.
was mostly the aspiration pneumonia, which we didn't know about so much in those days, right? So, and that was what led to censoring of events after 5 years, right? And
Yes,
because there was an overwhelmingly large number of patients who died because of causes not related to the cancer.
yes,
Okay. Now, what about what you call? So after that, you had various other organ preservation. Now, supposing this patient had been considered for organ preservation, patient had subglottic extension, but no cartilaginous involvement. What is the form of organ conservation that you may have? That is why you need to know the options for organ conservation. What would you have thought about? What organ conservation, strategies would you have thought of?
Ma'am, either giving the patient NACT followed by concurrent chemoradiation or upfront chemoradiation.
What is the induction chemotherapy regime that you may have chosen?
Ma'am, for induction chemotherapy, the TPF regimen, that is
Why?
taxane. Ma'am, the tax studies and in the Tremplin trial, they have
Tremplin.
shown.
What did Tremplin have? So essentially the results of 3 drugs versus 2 drugs. So then you have the tax
Yes, ma'am.
323 and the tax 324,
324.
and afterwards the other drugs with the Tremplin 2. Okay.
Yes,
Then what
ma'am.
happened? Then after that, how did you decide whether it should be concurrent CTRT or it should be induction followed by CTRT?
Ma'am,
Are there
actually,
studies in that space also?
Yes, ma'am. There are studies in that space also.
And what do they tell you, to do induction or to do CTRT?
Ma'am, the outcomes have been similar in the studies.
No. So this is one thing that you will have to read about the DECIDE and the Paradigm trials and the study by Ghee,
Ma'am,
where
but
they have compared the results of CTRT versus induction followed by CTRT. And Ghee's trial is the only trial that is possible for positive for induction followed by CTRT. Is there a scope of doing induction chemotherapy followed by RT alone? I'm telling you, without cartilaginous involvement. That means it is not a T4.
Yes, ma'am. So the VA trial and the EORTC, they had
No.
induction.
So you'll have to talk about more recent studies, and the more recent studies, you have various meta-analysis telling you that the results of induction followed by RT alone versus induction followed by CTRT are not very different. So you have the MAC NPC, which actually looks at this. Okay, the last MAC NPC that has been published, it talks about, if you look at the order of non-surgical organ preservation, what are the three options? One is hyperfractionated with concurrent CT. Then there is induction followed by locoregional therapy. Then there is induction followed by locoregional CTRT. And then there is CTRT. But the last three, actually, there isn't too much of a difference in the hazard ratios. Okay? You need to know this because you're doing MCH, so head neck oncology. The next thing that I'd like to ask you is about function. How will you, what kind of follow-up will you do in your patient? One is surgery followed by adjuvant therapy, and one is organ preservation, after organ preservation strategies. What is your follow-up strategy going to be? And quickly tell us what is it that you're going to look at in all the follow-ups. Unless, of course, anybody wants to ask anything more about the treatment.
No, you can continue.
So what is your follow-up strategy going to be in this particular patient where you've had surgery done followed by adjuvant RT plus minus CT? So what is your follow-up strategy going to be, and what are you going to see at each follow-up?
Ma'am, initially the patient will be on feeding tube. So after 2 weeks, I would like to do
why should the patient be on a feeding tube? Why are you so sure of it? When do you take the patient off the tube? After surgery? And is it essential that then why are you saying that the patient is on a feeding tube? All patients on radiotherapy don't need a feeding tube. So what is the percentage of patients who are on a feeding tube? And what are the indications of putting in a feeding tube? Yeah. So then, no. So I'm saying that the patient has had surgery, has completed his adjuvant therapy. So now your patient is coming on follow-up. Last day of radiotherapy, what is going to be advised to this patient?
Ma'am, I'd like to do a speech and swallowing evaluation fees for this patient.
Or what?
For speech and swallowing evaluation to see for if there is any dysphagia.
Okay. Dysphagia. All right. Then? Come, Labdi, fatapat bolo. I think we are nearing the end of the session. Bolo. How frequently are you going to call this patient?
Ma'am, 6 weeks, and I would like to do imaging after 12 weeks of completion of adjuvant treatment.
What imaging will you do?
I'll do a PET scan for the patient to look at.
What response are you looking at? This patient has had surgery followed by adjuvant therapy. So what response? I'm not saying you're wrong. I'm not even saying you're right. But then what response are you going to assess? Essentially, this imaging is going to be what? A baseline for you for further follow-up, right?
Yes,
because you've had surgery, you've done R0 resection followed by adjuvant therapy.
Yes,
so this patient, you're going to call on follow-up. First, you said at 6 weeks. Why 6 weeks? Why so early?
Ma'am, for swallowing evaluation for dysphagia, to look for dysphagia.
Okay, then you will do all of you do that because sir,
Hello.
KK,
No, you
Hello?
mean to say after the
completion of treatment.
adjuvant, when do you call?
Yeah.
Okay.
Yeah,
We
yeah.
usually have a monthly follow-up, madam. But that is our
Oh.
institutional protocol. I'm not sure what others do. Yeah.
Okay, so I won't contest it if you say that 6 weeks you're going to be calling the patient to look at the speech swallowing therapy part of it, and then you will do some form of an imaging after 3 months, and then use that as the baseline. After that, then every time that the patient comes to you, what all are you going to look for? What all are you going to do? You say you call every 3 monthly for the first
every
1.5 year. So what
Yes.
all will you look at?
So I would look at the stoma, the TP.
One is you look at disease control, then you will
Disease
look at
control.
toxicity.
Yes,
And then
ma'am.
you have to, of course, emphasize, as Ashok has written on the chat, that of course you will also always counsel the patient about habit cessation, right?
Yes, ma'am.
Because you don't want them to go back to smoking or drinking. Yeah.
Yes, ma'am.
And then this kind of a protocol you will continue for how long? Because see, this is completion of the treatment. Then
Yes.
after that, you will continue with this 3 monthly follow-up for
2 years, ma'am.
1.5 to 2 years. Yeah. Okay. Then every time will you
Followed
do
by
an imaging? Or you will
no,
do an
ma'am.
imaging annually?
No, ma'am, not every time. I would do a clinical examination with a Hopkins examination and imaging only if indicated.
Okay.
Madam,
Now there is a yeah. Please
given
go
you-
ahead.
Sorry, madam, for interjection. Madam has given you a hint.
Yearly.
Do you need to look at the chest of this patient? What is the incidence of second primaries in such patients who've got history of tobacco abuse?
Yes, ma'am. There is in focus there is a risk of second primary in
So
the
what is it?
15%, 10 to
At
15.
you need to know all this, Labdi, because it's important. These are patients who have been habitual smokers. You
Yes,
said
ma'am.
this one was a BD smoker, right?
Yes, ma'am.
So you have to have your be aware or rather alert to detect any kind of second primary.
Yes, ma'am.
5% per year with an incidence of about 15 to 16%, right?
Yes, ma'am.
Okay. Any other question?
I think we will conclude. Is that okay?
Thank you, madam. Thank you, Vikid sir.
Sir, anything else?
Dikru sir?
Dekru sir has left. He had some other meeting to attend.
Okay. So, Labdi, you did fairly well, but I would suggest a little more reading.
And Labdi, read Lisa Licitra's reanalysis of RTOG 1991-11. So there are a lot of review articles. You can read that. All the information is available on that.
Yes, sir.
And the other thing, you also have to know that you gave us very good reasons for why not to consider organ preservation in this group of patients. But I think you need to read Hoffman's paper as to what happened after organ preservation became prevalent.
Yes,
Okay.
ma'am. Yes, ma'am.
And then you'll understand why not to do it in a particular kind of patient, and why all these organ conservation, which were pivotal organ preservation trials, what were the fallacies of all these trials? Though they said stage 3, stage 4 cancers, depending on the staging prevalent at that time, what was the proportion of patients of glottis, supraglottis, and pyriform sinus? Even
Yes.
if you look at the hypopharynx trial of Lefebvre, you will realize that those hypopharynx that he called were actually supraglottic larynx. Okay. So
Yes,
all
ma'am.
these things you will need to know just because you're doing MCH head neck, right?
Yes, ma'am.
Okay.
Thank you.
Thank you, madam.
Thank you. All the best.
Thank you so much. Thank you so much,
Thanks.
Sarvani ma'am, KK sir, and Anil Dekru sir, and Dr. Abhishek sir for joining. And Labdi, don't get disheartened. We have been doing very well.
Yeah, you've done well. Huh? We just asking you too many questions because you were answering. Okay.
Mhm. So thank you so much, and thank you everyone, and a very happy Teachers Day to everyone. Thanks a lot.
Thank you.
Yasin. Bye.
Thank you. Bye. Bye.
Thank you, sir.
Good night,
Thank you.
madam. Good night,
Good
sir.
night.